All right. So sympathetic. One more time. I told you guys already what to expect because the basics. Sympathetic thoracolumbar, parasympathetic craniosacral. Enough? No. What thoracolumbar? From T1 until L2. The rest is not part of it. Very important. Lecture and lab. Parasympathetic craniosacral. What do you mean by cranium? Brainstem, the three parts. What do you mean by sacral? 2, 3, 4, to be more specific, right? So the rami from all of these, from T1 until L2, it will end up making the sympathetic chain going into the ganglia. From the ganglia, the long postganglionic is going to reach the organs. What's the only exception for that, for the sympathetic? How many ganglia do we have in the sympathetic? Three. Sympathetic chain, bilateral, one on either side. And then you have the collateral or prevertebral. It's one. Both of those, same thing. Short preganglionic, long postganglionic, right? Because the ganglia are right beside the spinal cord. It has to be short. The only exception to that is the adrenal medulla, and I talked about it already. The one that secrete epinephrine, norepinephrine, also known as adrenaline, noradrenaline, because the preganglionic is long, exception, just one. And there is no postganglionic. It's hormones. Okay? Here is the collateral ganglia. And these ganglia are part of the sympathetic. Remember three, sympathetic chain, collateral ganglia, and the suprarenal. The way collateral ganglia, the way the nerves reach their target is through a nerve known as splanchnic nerve. You need to remember this. Splanchnic nerve. This is the nerve that take these fibers in the posterior wall of the abdomen until it reach the different organs. Some of these collateral ganglia, one of them is called celiac. Okay, collateral ganglia. Ganglia is a plural of ganglion, right? Ganglion is one. Ganglia is multiple. So what are the collateral ganglias? Or ganglia, I mean. Celiac is one of them. And this is going to innervate stomach plus liver, gallbladder, pancreas, and spleen. So I want you to know just this little piece of extra information. Collateral ganglia. We have specific ones that we need to know. And what are you feeding? That's what I want you to know. What are you feeding? Stomach, liver, gallbladder, pancreas, and spleen. How about the superior mesenteric? Superior mesenteric is going to give small intestine and the proximal two-thirds of the large intestine. Inferior mesenteric is going to give the rest, the other third of the large intestine, plus reproductive and urinary system. So I usually like to do it this way just to make it a little bit easier for you. How many ganglia do we need to know for the collateral? Three. And here's how I like to do it. This is the esophagus, this is the stomach, small intestine, right? Ending up going to the large intestine. It should look like this. Here's a large intestine. Okay? So I'm going to divide it as follows. Stomach, this, plus what's beside the stomach? Liver, gallbladder, and pancreas. All of these are under the stomach. This is celiac. All right? What's after the stomach? You see the small intestine? Large intestine until here. You see this part? This is the next one, superior mesenteric. The rest of the large intestine plus urinary and reproductive. This is the last one, inferior mesenteric. Stomach and what's related? Celiac. Small intestine and two-thirds of the large intestine. Superior mesenteric. Remaining of the large intestine. Urinary reproductive, inferior mesenteric. That's it. Okay? That's what I want you to know in this part. The adrenal medulla, on the other hand, I already talked about it. Simply, it's a modified sympathetic ganglia. Ganglia in the fetus, it moved, modified, become bigger, settle on top of the kidney. So we call it suprarenal. Supra is above, or adrenal. Ad means above. It's the same thing. And the secretions here are epinephrine and norepinephrine. The other name is adrenaline, noradrenaline. You need to remember both names. Adrenaline, epinephrine. It's the same thing. Adrenaline, above the kidney. Epinephrine, above the kidney. Same name. You should remember both of them. Epinephrine is the vast majority. You need to remember that as well. So we release both of them, but epinephrine is the vast majority, about 75 to 80%. Okay? So what's going to happen is these hormones, those two hormones, they are going to be released from the adrenal medulla, circulate in the blood until it reaches their target organ. Okay? That's it. Sympathetic activation, I talked about it already. Sympathetic activation, fight, fright, flight, or fight, flight. And you know what's going to happen during crises, during fight, heart rate, blood pressure, and all that stuff. And I talked about what's controlling the autonomic nervous system in general, which is the hypothalamus. Okay, and these are the same things we talked about it a couple of times before. What happened during sympathetic activation? The next is basically the neurotransmitters that are going to be working with the sympathetic nervous system. In the preganglionic, are we following? There is a ganglia, there is preganglionic and postganglionic, right? These are using different neurotransmitters. The preganglionic in a sympathetic is using acetylcholine. This is what you need to know. This is a ganglion. This is preganglionic, short. This is a postganglionic, long. So what are you using here in this part? It is acetylcholine. The rest, adrenaline. Ganglionic is adrenaline. Next part is, again, I'm highlighting the most important parts. More details, don't worry about it. Okay? What's the next part? Next part is when you reach the target organ, you are going to work on receptors in order to do the work. And the receptors for the sympathetic nervous system are alpha receptors, in which there is alpha 1 and alpha 2, and there are beta receptors. We did the first part. Are we following? Sympathetic, with the preganglionic, with the ganglia, and postganglionic. At the end, we are at the organ now, at the target organ, right? How are you going to activate that organ or stimulate the organ? The organs have receptors. The first type of receptors in the sympathetic is alpha. There is alpha 1 and alpha 2. Alpha 1 is more common, and it is more in the smooth muscles, and you do need to remember this. And when you stimulate them, you're exciting them, so the smooth muscles are going to contract. Alpha 2, on the other hand, they have inhibitory effects. not stimulatory like alpha 1. Alpha 1, stimulatory, alpha 2, inhibitory. The other type is beta receptors. And beta receptors is located, remember alpha 1, that was smooth muscles, like blood vessels and smooth muscles in general. Beta receptors are located in skeletal muscles, lung, heart, liver. It's in the rest of the organs. And it's going to work through intermediary, which is called cyclic AMP. This is how they work. There are subtypes of beta as well. I have alpha, I have beta. Alpha subtypes 1 and 2. Beta subtypes 1, 2, 3. 1, increase metabolic activities. Beta 2, relax smooth muscles of the respiratory tract. Relax smooth muscles of the respiratory tract. What does it mean? There are smooth muscles in my respiratory tract, right? Like the bronchi, the bronchioles, the tract in general. So what do you think will happen if I contract them? Contract them means it's going to constrict, right? If you relax them, it's going to dilate, right? So when you stimulate beta 2, they are going to dilate. Why? Relaxing the smooth muscles. Beta 3 is not the most important one. It's lipolysis, breaking down lipids. That's okay. It's more important to remember beta 2 is the most important one. You have to know it's beta 1, beta 2, beta 3. 1, metabolic activities. 2 is the most important one, respiratory tract. And this is important. I think we all know about the bronchial asthma, right? We're familiar with bronchial asthma. What's bronchial asthma? Something that happens that trigger the smooth muscles in the respiratory tract or tree to constrict. And those patients, they end up getting these wheezes because the respiratory tree or the respiratory tract constrict, right? So they don't breathe that well. They go like something like this because that it's supposed to be like this and it's getting smaller. Why is it getting smaller? The smooth muscles contract. Why did they contract? Most likely it's allergy, but it can be infection, it can be anything else. Whatever happened, if the smooth muscles are contracting, you're doing something called bronchoconstriction, which is bad. You can't breathe well, right? So here is a question for the A student. If that the case, and remember I'm telling you beta 2 is in the respiratory tract. If this is a patient who's having bronchial asthma, what should I give him? Something that stimulate beta 2 or something that inhibit beta 2? Stimulate. And this is basically the inhaler that those patients take. You see the inhaler? There are different types of inhalers, but the most common one is the one that most people use, which is called beta 2 agonist. You know agonist and antagonist? Agonist with, antagonist, agonist, right? So that's what they take basically. They take the inhaler. I know that most of the inhalers now, they have cortisone, which also relax. But I'm talking about these receptors specifically now. So what should they get? Beta 2 agonist. Something to stimulate beta 2 because their function is to relax smooth muscles. And this is what they get. They get this rescue inhaler. What's the rescue inhaler? Beta 2 agonist, beta 2 stimulant. Is that the only thing available there? No, actually, I just told you guys about alpha. What does it do? Alpha, stimulate or relax the smooth muscles. It's right here. Stimulate. So is that good or bad? It's going to constrict. So same meaning. Should I give them alpha 1 stimulant Agonist or antagonist? Think about it. What's alpha 1 doing? Contract the smooth muscles everywhere, including the bronchi. Constrict. What should I give those patients? Antagonist. So what kind of treatment? Beta 1 agonist or alpha 1 antagonist? Is that clear? This is how it goes. Okay? Sometimes I ask questions like these for the students like 90s and 100, and you should get it because it's deep understanding. Okay? By the way, the exams, I usually, first of all, the exams are already in the bank, and it's in the instructor's bank. Okay, I'm not making up questions. I just pick it in categories. I give you some very easy questions. Anybody can get it, no matter what, and then a little bit harder, and then like average, above average, hard, and then like the 90 something, high 90s students. This is the highest, and I'm actually explaining everything to the depth, including these, like this question right here. It's deep thinking. What should I give those patients? If you just memorize, you wouldn't get it. But let me think about it. Beta 2, relax. Yeah, beta 2 agonist or alpha 1 antagonist, right? It just need you to think about it a little bit more. All right. So sympathetic preganglionic use acetylcholine. Are we following? Do you know that we have sympathetic, parasympathetic, right? Preganglionic, postganglionic, right? Short, long, long, short. Is that okay so far? What? So we have four spots now, right? Preganglionic sympathetic, postganglionic sympathetic. Preganglionic parasympathetic, postganglionic parasympathetic. All of them use acetylcholine, except one. Postganglionic sympathetic. Clear? Just to make it easy. Here it is. Is that sympathetic or parasympathetic? Sympathetic. Okay? And this? Sympathetic or parasympathetic? Parasympathetic. Right? Are we following? Okay. So here is one, two, three, four spots. The only one spot that use adrenaline is this. The others, they use acetylcholine. That's it. Okay? So hopefully if I ask you a question like this, you know what I'm talking about. This is noradrenaline. How about one, four, three, and four? Acetylcholine, acetylcholine, acetylcholine. I think that's easy, right? You have four spots, three of them already acetylcholine. That's it. So just remember the one that's different, and that's it. Postganglionic sympathetic. This is the only one. Okay? Is all postganglionic sympathetic use adrenaline? No, even this one exception is not 100%. Because in certain spots, like blood vessels, skeletal muscles, and brain, still acetylcholine. Okay? So is all of this norepinephrine? No, there is an exception. Even this. Minus. Okay? Minus brain, skeletal muscles, and sweat glands. Sweat glands, yes. Blood vessels, sweat glands. So even norepinephrine is only one out of the four, but not even all of them. Okay, so it's a very little use, but you still need to know this. Okay, other than those two, adrenaline or epinephrine, norepinephrine, other than those, and acetylcholine, this is the most common. In certain parts, we have nitric oxide. Nitric oxide, go to some of the blood vessels and dilate them, okay? Like skeletal muscles, brain, and the reproductive system as well. It vasodilate in these specific spots, okay? Its dilating effect. And just for your information, if you are interested to know, nitric oxide is the basics of, or based, the mechanism of action of Viagra and Cialis. We hear about those, right? It's based on this, nitric oxide. It stimulates nitric oxide. Nitric oxide is dilating or constricting to the vessels, dilating. So more blood, more erection, and so on. So just to remember nitric oxide, it's vasodilating. Parasympathetic is craniosacral. What do you mean by cranial? Brain stem. What do you mean by sacral? 2, 3, 4. Are the ganglia close to the spinal cord or close to the organ? What do you think? The ganglia of the parasympathetic close to the organ or close to the spinal cord? It's close to the organ, and that's why long preganglionic, short postganglionic. Okay, so see, this is very close to the organs. And when I say very close to the organ, here is what I mean. It's either very close to the organ or within the wall of the organ. Because of that, we have two types, terminal and intramural. Terminal, near the organ. Intramural, inside the wall of the organ. Did you get the difference? We have two types. Both of them are close to the organ, close or in the wall. If it is close, terminal. If in the wall, intramural. Parasympathetic, how do you reach the brain and reach the organs? 3, 5, 9, 10, 3, 7, 9, 10. This is important to remember. I told you, was Monday, I think. I told you guys that these nerves are not like moving in a space like this. Like you're going from this point to another city, you take a bus, right? You don't go like walking like this. So these nerves are not like moving in a space like this. They jump on something like a bus. And you have 4 buses, 3, 7, 9, and 10. And you should remember this. So 3, 7, 9, and 10, right? 3, 7, 9, and 10. 10 specifically is the vagus nerve. And do we know what vagus mean? I mentioned it before. Translation. What's vagus? Nobody? Vagus, wandering. The wandering nerve. Because it's wandering around all this area right here. Everything. Okay? 75% is on this one. And that's why if it is 75%, it's wandering in this area, huge territory, because it's carrying about 75% of all these organs with the parasympathetic supply. So what's the vagus nerve doing? Carrying 75% of the parasympathetic supply. How about the other 3? I said 3, 7, 9, 10. How about 3, 7, and 9? Just 25%. And again, vagus means wandering. There are also pelvic nerves that will take the innervation to the organs. Pelvic nerves. Remember the splanchnic nerves in the sympathetic, if you are following with me? Splanchnic will take it to the organs. Here, it's pelvic nerves take it to the organs. Parasympathetic effects, we shouldn't spend much time here because we already know. If you know the sympathetic, it's the opposite. That's it. The parasympathetic is the opposite of the sympathetic. All of them use acetylcholine. Look at this right there. You can take a picture of that, if it's going to help you. It's summarizing it for you. Okay. So what are we using? Yes, preganglionic and postganglionic, both of them is acetylcholine. That's it. Now, we talked in a sympathetic about the receptors. We have alpha and beta. Do you remember this? Alpha and beta, alpha 1, alpha 2, beta 1, 2, 3. For the parasympathetic, we have two types. One of them is called nicotinic, and the other one is called muscarinic. Oh, where did you get these names from? Like, what did you call the receptors these names? Because they use a chemical compound in the laboratory to stimulate these receptors, and they found that nicotine stimulate these receptors. So they call it nicotinic, nicotine like in cigarettes. And they use another thing that's called muscarine, another chemical, to stimulate the other receptors. So what are the receptors here? Nicotinic and muscarinic, because of nicotine and muscarine, chemical compounds. Now, those, you need to know the location. Where is it? Like, same as we mentioned before. Do you guys remember? Alpha 1, contract, right? Smooth muscles. Alpha 2, and then beta 1, beta 2, which each one of those is located. So the location here is the ganglia of both of them. So you hear nicotinic, you say ganglia. That's it. What is a nicotinic? In a ganglia. Sympathetic and parasympathetic. That's it. Muscarinic, it's everything else. Nicotinic, ganglia only. Muscarinic, anything else, including neuromuscular junction, neuroglandular junction. It's basically anything else. So nicotine is what stimulates the nicotinic receptors, and muscarine is what stimulates the muscarinic receptors. But muscarine, again, was used in the lab. And in our body, that's normal. We have very tiny amount of muscarine that work on these receptors, um, or generally speaking, they can respond to it. But there are some poisonous mushrooms that, if given, it can kill somebody. It can kill anybody because you can constrict all these organs, and this will end up very high activation of the parasympathetic, and this can lead to death. One more thing here. Does the sympathetic dilate or constrict the bronchial tree, generally speaking? Sympathetic is fight, flight. Does it dilate or constrict bronchial tree? Do you need to breathe more or less during the fight? Do you dilate or constrict? How about the parasympathetic? Constrict. It's always the opposite. Sympathetic dilate, parasympathetic constrict. Clear? Okay, if I want to give you another medication, can I give you something to dilate? Yes, beta 2 agonist, isn't it? Can I give you something to prevent the constriction in a different way? This is another medication that block the muscarinic receptors. It is a medication that already exists. Another ventilators or these rescue inhalers and the inhalers. There are some of them. So bronchial asthma, what should I give you? I can give you beta 2 agonist or muscarinic antagonist, anti-muscarinic. What's a muscarine? Parasympathetic, isn't it? Did you get the idea? Sympathetic dilate, parasympathetic constrict. So you have two ways to take care of this. Either stimulate the sympathetic to dilate or inhibit the parasympathetic to dilate. Did you get my idea? So you should remember this. We already talked about this, 3, 7, 9, and 10, and it is S2 to S4. We already talked about it. And this is the sympathetic, and this is the parasympathetic comparison. Look how the preganglionic is short and the postganglionic is long in the sympathetic. while in the parasympathetic, the preganglionic is long and the post is short. Here it's short, long, except for the ganglion. Now there is something called dual innervation. Dual means do, like two, right? Dual innervation. Practically speaking, do we receive sympathetic or parasympathetic in our organs, or both of them? Both of them. Like, think about it. I just told you, bronchi, do you receive sympathetic or parasympathetic? Both of them. Sympathetic, dilate, parasympathetic, constrict, right? How about the heart? Do you receive sympathetic or parasympathetic? You can accelerate, you can speed up, and you can slow down. Both of them, right? Respiratory rate, both of them. So we have, most of the time, we have both of them. And there is always a balance like this. Okay? Sympathetic is pushing on one side and the parasympathetic, and there is a balance. And depending on the situation, one of them will take the upper hand. Clear? What do you mean? I mean, if I'm in the middle of the fight, sympathetic take the upper hand. Right? So sympathetic is trying to speed up the heart, parasympathetic slowing down the heart. There is a balance. No, not the balance anymore. If you are in this situation, you don't need the balance. You give the upper hand to the sympathetic, accelerating the heart, right? How about if I'm resting, digesting? The parasympathetic take the upper hand. Clear? There is balance, but there is a balance between sympathetic and parasympathetic. If you are in a sympathetic situation, fight, flight, sympathetic take the upper hand. So what's going to happen? Sympathetic activity. If you are in a parasympathetic situation, which is the normal, by the way, you should be in the parasympathetic. That's the normal. That's the resting. Sympathetic is just something occasional. If you are in a fight, are you fighting like day and night? Of course not, right? So parasympathetic is the normal. So because of this dual innervation, they come together and go to the organs, making different plexuses. These plexuses are cardiac plexus to the heart, pulmonary plexus to the lung and the bronchial tree, esophageal. I think the name gave it away, right? Think about it. Cardiac plexus to the heart, the plexus to the heart, the dual innervation to the heart. Pulmonary. Do we know what pulmonary means? Respiratory? Lung? Lung. Esophageal, esophagus. Celiac, inferior mesenteric, and hypogastric. I will talk about those because these are the rest of the organs after the esophagus. So cardiac and pulmonary, both of those go to the heart and to the lung. Just this. Cardiac go to the heart. What if I ask you what's a cardiac plexus? It's a plexus of the dual innervation, both sympathetic and parasympathetic, to the heart. That's it. Pulmonary, dual innervation to the lung. Esophageal, dual innervation to the esophagus. Okay? Esophageal, it's goes to the esophagus. Celiac, abdominal viscera, in association with the inferior mesenteric. So celiac and inferior mesenteric, they go to the abdominal viscera. Hypogastric to the pelvic viscera. Again, are we following? Are we good? Cardiac plexus, heart. Pulmonary plexus, lung. Esophageal plexus, esophagus. Okay? Celiac plexus, followed by the inferior mesenteric, abdominal organs. Hypogastric, pelvic organs. What are the pelvic organs? What do you have in your pelvis? Urinary system and reproductive system, isn't it? Do we know that? Yes, that's it. Here are the different plexuses. Autonomic tone. Do you guys remember the muscle tone when I told you that there is always a tone even at rest? Your muscles are not like 100% relaxed, except after death. I mentioned that, right? When they hold somebody's hand like this and it drops, it means no muscle tone. This is only death. As long as you're alive, there is a tone, a minimal amount of muscular activities that you don't even feel it. Same thing here. We always have an autonomic tone. It's not like sympathetic doesn't give up 100%. It's not zero. There is always a tone on which you can move toward the sympathetic or move toward the parasympathetic. And this is called the background level of activities. Okay, there is a background level. You can increase it or decrease it, but it's not zero. What's the function of each one of those plexuses? It goes without saying. What's the plexus? What's the function of this dual plexus going to the heart? Sympathetic, stimulate the heart, speed up. Parasympathetic, slow it down. That's it. Um, some organs, this is not like I mentioned these five plexuses, right? Did I mention every single organ in the body? Not every single organ. I told you cardiac for the heart, pulmonary for the lung, right? Esophageal for the esophagus, celiac, inferior mesenteric, abdominal organs, reproductive organs. Is that everything? No, not everything. Blood vessels, for example, they receive sympathetic. How can the blood vessels constrict and dilate? It's just by, if you activate the sympathetic, it constricts. Just don't activate it, it will relax. No need for parasympathetic. Okay? The regulation of these autonomic functions happen in different levels. The most important one is the reflexes that work according to the situation. When something happens, blood pressure drops. Do you remember these? Is it the sinuses or the bodies? Can somebody tell me? Blood pressure. Which one responds? The sinuses or the bodies? Hmm? It is, what do you think? Baroreceptors and chemoreceptors. Baroreceptors are sinuses. Chemoreceptors, bodies. Okay? So it is the sinuses. The sinuses, aortic sinus and carotid sinus. Do you remember this? I told you, very important. Okay? The sinuses. So what happens if the blood pressure drops or the blood pressure goes up? Reflex. If it goes up, stretching these aortic and cardiac sinuses, sending a signal to the brain stem, slowing down the heart, and vice versa. So this is the basic control, plus the brain stem have the upper hand on it. Um, the hypothalamus has the upper hand as well. The viscera also have their own reflexes that I just talked about. What is the reflex? We talked about it before. Do you remember the reflex? Receptor, afferent, control center, efferent, effector. Do you still remember this? The reflex. Autonomic or visceral, same thing. But there is a difference here. The difference is these reflexes can be short or long reflexes. And this is something that I want you to know. Short and long reflexes. What's a reflex in general? Receptor, afferent, control center, efferent, effector. We talked about it several times, right? We have something like that in our viscera. But there are two types, long reflex and short reflex. What's the difference? It's the involvement of the central nervous system or not. The only difference is where is the control center. Are we following still? Here's what I mean. Any reflex, receptor, afferent, control center, efferent, effector. I think we all know this, right? But we always mention that this control center is the central nervous system. On the autonomic nervous system that we're talking about, this doesn't have to be the case. If the central nervous system is the control center, we call this long reflex. Do you have another control center? Yes, ganglia. the ganglia beside the organs, like here. So it goes like to the ganglia and go back. Does it go to the nervous system? No. Did you get my idea? So afferent receptor, afferent ganglion is the control center, efferent effector. Did I involve the central nervous system here? This is short. How about this? Receptor, afferent, control center, efferent effector. Did I involve the central nervous system here? Long. This is what we need to know. And just understand the rationale. Why are you doing that? Because there are certain things that you don't have to use the central nervous system. It's too simple to use the central nervous system. Example, what if I'm eating and the food is right, like this is the intestine, the food is here, and you just want to push it down to the next segment. Why do you need the central nervous system, right? All what you need is just use the ganglia, contract this segment, and relax. The food will move. Why do I need the central nervous system here, right? It's too simple to use it. So contract, relax. That's it. Who is taking care of this? Ganglion. But there are others that are more complicated than that, and it need the involvement of the central nervous system. Example. I gave you two examples that you need to know for the long one. The long one is used in more complicated situations, something like the gastroiliac reflex. This is 2 points that's too far away to use a ganglion. Are we still following here? Like what? Like when the food is in the stomach, okay? It's been there for some time. And it is about time that you're going to eat the next one. Do you still need the food? You're going to empty the stomach, right? If you're going to eat, you need to empty what's there already, right? And in order to do that, you need to empty the intestine. So if that's the case, before I send the contents of the stomach to the small intestine, I want to empty the small intestine by opening the ileocecal valve. So the contents of the small intestine leave, go to the colon, clearing the way, empty the space for the new load to come. So what are we coordinating? We are coordinating the stomach here to the ileocecal valve at the end here. It's two separate areas away from each other. Long reflex. What kind of ganglia can mediate? Like my stomach is here, okay? My stomach is here, and my ileocecal valve is here. What kind of ganglia can mediate this? This is too far away and too complicated. Long reflex. Another one is defecation and urination reflexes. These also need the involvement of the central nervous system because it's more complicated. Uh, it's more complicated process. So here is the short. Does the short use the CNS? It use what? Ganglion. It use a ganglion. What is the control center? The ganglion. How about the long? You involve the CNS. Okay? And short reflex, if there is something that's too simple, two parts beside each other, you can use the short reflex. Look at this. Stimulus, afferent. Look at what is this? This looks like the shorts, right? Look at this ganglia. And then you go back. This is a long or short? This is the short. Look at the long. You go to the central nervous system, you have an interneuron, and then you go back and do the effect. So we have long and short. Long reflexes, this is the one that's coordinating most of the activities. That's especially if it's far away from each other. Short reflexes are involving like more simple reflexes. And it's I told you the ganglion, right? The ganglia. The ganglia are part of another system that's called enteric nervous system. This is a local system in the digestive tract. Okay, go from this point to the ganglion beside it, enteric nervous system, and you go back. You're not involving sympathetic or parasympathetic. In the short reflex, in the long, you do. So what's the enteric nervous system? The enteric nervous system, is that sympathetic or parasympathetic? It's none of those. It's a separate entity, not sympathetic and not parasympathetic. It works with the digestive system, and enteric is coming from intestine, which means digestive system. So it's a third category that involve the ganglia of the nervous of the digestive system that I just talked about. And the enteric nervous system is what mediates the short reflex. But you said the ganglia. Yes, ganglia is part of the enteric nervous system. Any other higher functions should involve the medulla oblongata. What do you mean by higher functions? Any one of those is a higher function. This is not something very simple, like salivation, swallowing. Swallowing is not something easy at all. Like you think about it, what swallowing, just the food move in, right? No, that's not true. Swallowing is more complicated than that. When you swallow, you know what you do? After you chew the food, your tongue will push it backwards, but before doing that you have to close the exit going to the nose, otherwise the food go to the nose. You need to close the exit going to the air so it doesn't go to the air, and then you push it backward to go to the esophagus. This is not something that's simple, right? It's when you think about it, swallowing, just swallow, food goes in. No, you have to close this, you have to close this, you have to move this up and push the food backward. It happened automatically. We don't even think about it. But again, this is a higher function. Digestive secretions, when and how much you secrete. Okay, these are all higher functions. Peristalsis. Peristalsis is this movement pushing the food down the digestive tract. Urinary function is also complicated, and all these higher functions are controlled by the hypothalamus. The autonomic nervous system and somatic nervous system, they integrate with each other, they work together because of the cerebral cortex. Cerebral cortex is the head of the somatic nervous system, while the autonomic nervous system is controlled by the brainstem, and the head is the hypothalamus. But cerebral cortex via the limbic system also work on the hypothalamus. Let me say it again. Who's the big boss for the somatic nervous system? Cerebral cortex. Who is the boss for the autonomic nervous system? Hypothalamus. But cerebral cortex have an effect on the hypothalamus. This is integration through the limbic system. Remember the limbic system? What are the two things to remember about the limbic system? What the M remind you? Memory and emotion. Memory and emotion. Okay? Does the memory and emotion reflect on our autonomic function? Yes. Don't you feel like I need to go to the bathroom now when there is a situation or something? Don't you feel like that? This is coming from your cortex. This is awareness? Like you are in a situation that you're scared of something. Scared of it means you're conscious, right? This is a cortex. So the cortex does have an effect, and this is the integration between those two systems. These higher functions require cerebral cortex, and part of it is conscious and part of it is unconscious. Memories is one of those. And memory is you store a memory for something, right? It can be a fact memory, something specific, right? This is chair, this is computer, just facts, okay? But there is another one that's more skill memory, which is you get a memory of what you're learning, like piano, guitar. Is it the same today versus a month later versus a year later? Do you play the same level? No. you improve more and more and more because this is skill memory. But this is a computer. I know this is a computer. There is no skills here, right? This is fact. The fact, simple. 1 + 1 is 2. That's it. But others need some training and some practice. It's learning behaviors. And this should be coordinated, unlike the fact memory. Fact memory, one piece of information. This is laptop. That's it. This is cerebral cortex. The learned one or the skill one, it need more work. Basal nuclei, cortex, and cerebellum are involved. So now I'm my first time to play piano. All right. Why is it hard? Because it's not the cortex. It's the cortex plus the basal nuclei for the basic pattern and the cerebellum for the muscle movements. Right. You have to use all three to coordinate. And then you do again, you coordinate more, linking more. 3 times, 10 times, 50 times, it gets better and better and better because these three organs or three components, they are trained to work together. Now the memory can be short-term and long-term memory. Okay? Short-term memory is something, it's a small bit of information that doesn't stay for a long time. I'll give you an example. If I ask you something like right now, short reflex, does it involve the CNS or not? No. If I ask you tomorrow, you forget it. If I ask you in a couple of hours, you forget it. Right? Because this is short term. It's a small piece of information that you remember it right now. Right? So this is called the short term memory. Uh, how about like me? Do you think I will forget that? Never. I don't forget it. Why? Because I already consolidated this short-term memory into a long-term memory. Like, when I tell you BPM, remember about the cerebellum? That was like 25 years ago. How do I still remember it? Because I converted the short-term into long-term. Some students like the short term. So the few hours before the exam, I'm going to look at everything and just spit it or vomit that in the exam and just leave and it's gone. This is not a good way to do it. So, some students do it, right? So I'm going to take a look at it before the exam and it's still fresh in here and just put it in the exam and leave, but it disappeared. This is short term. You should consolidate to the long term in order to remember it. And the long term itself is two categories. There is second and third. How to consolidate? There are different ways to consolidate, and this can be a good advice for you, okay? If you wanted to understand about this concept. You hear something now, you remember it, if you're paying attention, this is short term. How to convert it into long term. Number one, repeating. The more you repeat, the more you consolidate. Believe it or not. You know how you consolidate your memory? There are physical changes, and I've seen that. Uh, it was a video, but it was very interesting that when they put like a camera on a plant or something, and the plant is growing, but you show it to you like fast, it was something like this. So they tell you something and they record the activities. So this is a neuron like this, okay? And they tell you something and the neuron is activated. You repeat, another neuron come to it. You repeat, another neuron come to make a circuit. This is the circuit to remember. You know what? When you repeat it more neurotransmitter came to this piece of information. You will never forget it. So repeating is one thing. That's number one. Number two is using more of your senses. Like when you see something is not the same as you see and hear it. Like if I sit down here and I don't do anything, I just leave this for you. Okay? Not as good as when I talk and you see it at the same time. If you're only listening to me, you're using one sense only, right? If you want it to get better and consolidate, look at both of them. Hear me and look at the same time. Pictures. This is a third one. So the more senses that you, how about I use my motor skills? Like I get a piece of paper and I do like, this is the brain, this is the spinal cord, this is additional one, right? The more you involve, the more sensations and the more uh, parts that you involve, the better it gets. So it consolidates short term to long term. But long term is not one, it is secondary memory. This is something that you remember. Let's say you're studying and you got it. So you can remember it tomorrow, you get the exam. Like the last time you studied something was today, okay? If it is in the long term, but secondary memories, you remember it until the exam, Monday, okay? Maybe a couple of days after that. But then it will fade away. Did it disappear? Not really. It doesn't disappear. Short term is the one that disappears. Long term doesn't disappear. Long term, secondary memories, it fades away. So, meaning, if you just look at it before the exam, you will refresh your information. Did you get the difference? Short term, it goes away. That's it. Done. Because you didn't form this. This is something called memory gram or memory circuit. You didn't make the circuit. You hear it for the first time and then it disappears. That's it. Repeat, do whatever you want. You're consolidating it. Now it's long term. Which long term? Secondary. So now does it disappear? Never. It doesn't disappear, but it fades away. So you need to refresh. The tertiary is doesn't even fade. But for something to go to the tertiary memory, it has to be something that's extreme, extremely pleasant or extremely unpleasant. I still remember when I was in my age. I still remember when I was 7, 8 years old and I was playing with my bike and I was just pulling I was moving the bike around and my finger got stuck in and I couldn't even take it out. I have to like move it and take my thumb out. This was like cut, hanging. I have to do a surgery to put it back. It was horrible. Do you think I will ever forget this? I was 7, 8 years old. Never, never. You have an accident. Do you ever forget it? Even if you're 6 years old, you will never forget it. On the other hand, if this is something exceedingly pleasant, you win a reward. If you ask somebody, do I remember like when I was like elementary school, I win something? Yes, exceedingly pleasant. So extremes go to the tertiary, which is part of the long term, never go away. Okay? Exceedingly pleasant, exceedingly unpleasant. Something extreme. That's the tertiary. So here it is, short term. You like what I told you right now, you don't study, it's gone. And that's why I always tell you study as soon as possible, right? Right? Study as soon as possible because today, remember it. Tomorrow, half. After that, it's over. You won't remember anything. Like, don't I ask you questions and you don't answer it, even though you were answering it like Tuesday or I mean Monday, right? It's short term, it's gone. But convert it, okay? Repetition is the most important and using more senses. So short term can permanently lose. If you consolidate to the secondary, it fade away. If tertiary, it will never fade away. What's helping us for this memory consolidation? Remember these three, four, amygdaloid, hippocampus, nucleus basalis, and cerebral cortex. These four are the ones that convert your short term to long term. So when you repeat, those are going to convert it for you. Amygdaloid, hippocampus, nucleus basalis, and cerebral cortex. Okay, good enough to know here. I'm not going to go into the details. I already told you. Just remember those. One more thing here, which is this. Okay, this is called the memory gram or the memory circuit. More neurons involved, more synapses, more neurotransmitter. You have to remember this. The memory engram. the memory circuit. What's a memory engram? What's a memory circuit? It's a memory for something specific. 2 plus 2 is 4. This is a circuit, right? How did you do this circuit? Repeating. So the neurons come together, right? Synapse together, more neuron synapse, more neurotransmitter together. This is the memory engram or the memory circuit. And you have thousands of these circuits inside your brain. Each one is, each piece of information, you know, thousands of facts, right? Each one of those is a memorygram or a memory circuit for each one of those. The more you repeat, the more you consolidate, the bigger the circuit. It doesn't go away. Here it is. You do more synapse. I'm just giving you the bottom line. How to do it? More neurons, more synapse, more neurotransmitters. Good enough to remember. Okay? Memory engram or the memory circuit. Here it is. Memory engram. This is single circuit for single piece of information. Synapse, more neurotransmitter, memory engram. There are certain things that can affect the memory. First thing is nature, intensity, and frequency. Like nature or intensity, you get a crash, right? You get a car accident. This is too intense and it's very bad nature. You remember it, right? Or something happened several times. Medications like caffeine and nicotine, they always say drink coffee and smoke cigarettes. It's going to help you. Is that true? Not as much as they say. It's not like huge, but it does. Okay, it doesn't mean I'm telling you to smoke or something, but it's just a fact. Does it stimulate actually those hippocampus and nucleus basalis? Does it stimulate them to consolidate? Yes, it does, but it's not huge. State of consciousness. There are different states of consciousness. It is not I'm conscious or conscious and conscious. No, there are certain grades in between. It's not on and off. Okay, there are different grades. Sleep is one of them, right? Do you remember when we talked about the waves, the alpha, beta, or beta, alpha, theta, and delta, right? So remember which one is beta? Concentration. Which one is alpha? Am I supposed to see any alpha right now in the class? No, because alpha means like this. Okay? Delta means you're sleeping, right? Theta only in children. So isn't this is different degrees of consciousness? Beta, you're concentrating. Alpha, you're started to lose your concentration. You're about to sleep. Delta is sleeping. These are different types of consciousness. And in sleep, there are two types of sleep that you alternate throughout the night. Okay? Basics. I'll just give you the basics. What happened during sleep? You go from beta, this is before sleeping, beta to alpha. You're not sleeping yet. Alpha doesn't count as sleeping. Okay? And then you go to delta and you alternate with something called REM throughout the night. Delta, deep sleep. D. Delta, deep. Delta is deep sleep. Okay? So does it mean that when I'm sleeping like for 7, 8 hours, is it delta? No. Delta REM. Delta REM. Delta REM. REM is rapid eye movement. Yes, it happened. You don't notice it. If somebody look at you while you're sleeping, you will see they will see your eyes going like this. Right, left, fast. Okay? So this is called REM. Why are we alternating between those two? Why don't we just have delta? Because they do different things. You gain, or it's good for you to go through both of them. What's the difference? The difference is during delta, which is the slow wave or the non-REM, your body relax, including your brain. Your brain relax. Okay? So your brain is taking the rest. It's taking a rest. Your heart rate, blood pressure, respiratory rate goes down. Is this good for your body to take a rest, to relax, right? This is happening during deep sleep. Still, why do we need the REM? Because this is the time for the muscles now. Your muscles. Your muscles relax, right? If it's all delta, your muscles didn't relax. Yes, you're not thinking, your blood pressure goes down, respiratory rate goes down. Yes, you're giving rest to those. You're not thinking, you're relaxing and everything, but your muscles didn't relax. Don't you need to relax everything? That's why we alternate. So during REM, the muscle tone dramatically drops. So now this is the time to relax your own muscles, uh, to give a break to your muscles. But your eye moves. There is no reason for that, or not no reason. We don't. There is no like very obvious explanation. You just notice that the eye move fast. But what we have to know is muscles. Muscles relax during REM. Everything else relax during the deep sleep. So this is the time to give your muscles a break. Okay. And the other thing is this is where dreaming occur, most of it. How to remember it? This is how I remember it. REM, dream, REM, dream. A little bit similar, kind of. This is how I remember it. REM, dream, REM, dream, REM, dream. Just to remember it. So what exactly happened here during sleep? You alternate between REM and delta or slow wave or deep sleep. Okay. And what practically speaking happen is it's not like this. It's not delta REM, delta REM, delta REM. No, it's not like this. It's delta REM, delta bigger REM, delta bigger REM, delta biggest REM, the last one. So as you go, the REM gets bigger, bigger, big. The first REM is short, next is a little bit longer, longer, longer. 5 minutes REM, deep sleep, 10 minutes REM, deep sleep, 15 minutes REM, deep sleep, 20 minutes REM. Did you get this idea? Of course, a lot of things happen during sleep. You're giving a break to everything. This is the time that you regenerate your energy, protein synthesis happen in the neurons, and so on. Look at the waves. See how this is high frequency? Do you see this, how it's relaxing? Here, see how slow? Look. Like in this area here, 1, 2, 3 blocks. I see two waves only. Look at here, 1, 2, 3 blocks. This is like 10. Okay, so this is high frequency. Delta is slow waves or low frequency. REM is kind of close to wake, but it is not. It looks different. And of course, we're not going to ask you like to know them from each other. That would be too much. But now look at this. You go to sleep. Look at the delta, and then you got a little bit of REM. Delta, more REM. Delta, more REM. Delta, more REM. Compare the REM, small, like 5 minutes, 10 minutes, 15 minutes, 20 minutes. Okay, that's why it's bad that you don't get enough sleep because you need that big REM at the end. Arousal, if you are awake, there is something, the way you get awake is, and remember these, I give you like a single word or two words or something, so please remember it. How do you get awake? I'm sleeping right now. I be awake, or something is going to wake me up if I got enough sleep. I will wake up by myself, or something happened, like you hear a loud sound, somebody turn on, somebody who's rude or something, turn on the light while you're sleeping, right? What happened exactly? Reticular formation turn on, and it will activate your brain, and you wake up. So remember this word: reticular formation and cerebral cortex. I'm sleeping. Noise. I hear noise. What's the noise going to do? Reticular formation and cerebral cortex. If that's the case, they are going to turn on your brain. You wake up. Got it? Don't forget this: reticular formation and cerebral cortex. So here is the reticular activating system. Reticular activating system, this is a system when it's activated, it wake you up. Okay? And as long as it is working, you are aware, you're conscious. This is the one, this is the one that if injured, you go to coma, right? What wake you up? Reticular formation, which is a reticular activating system related to it. RES, don't forget this. Reticular activating system. This is the system that keep you conscious, that wake you up, keep you conscious. What if it's injured? An accident or something? Coma. Did you get what the coma is? In a coma, why they don't wake up? Because what's waking them up is not working anymore. Most of the time, by the way, it's temporary. Like RAS, it can regain its function, and that's how you see like people in coma, and they stay like that for hour or two, or a day or two. Even sometimes they stay for a year, and then the somehow reticular activating system regain its function and regain consciousness. RES. So here's what can wake you up. You see something, somebody turn on the light, you hear something, or you got enough sleep. Reticular formation give a signal to the reticular activating system, and the reticular activating system stimulate your brain. You wake, you wake up, and your brain is activated. There are a lot of neurotransmitters in the brain, and we talked about acetylcholine. Acetylcholine. We talked about it several times. If you have less secretion of acetylcholine, some people can get Huntington disease, because acetylcholine is the one that coordinates or work on the muscle movements. So you have acetylcholine, your muscle movements are controlled. Okay, and that's why those people, they go like this, they move like random, like this, change direction. All of a sudden, if you see somebody like this is called Huntington disease. They have an issue with acetylcholine, which was controlling their muscle movement. You lose the control. Okay, is that the only thing? I don't want to go deeper than that, unless if you wanted to know or something, that's something else, but I don't want to go deeper than that. Serotonin. Serotonin, I think most of us know about the SSRIs. Anybody having like anxiety or depression or something, a lot of people having these issues, right? Serotonin responsible for two things: sleep, and part of the mood. Okay, your mood is controlled also by serotonin. The point is, if you have enough serotonin, you feel good, you sleep good. Clear? If you don't have enough serotonin, you can get depression or anxiety. Okay, so that's where the medications came. Prozac, citrulline, fluoxetine, all these medications, um, they help increasing the amount of serotonin. I'm making it like the simplest that I can. Okay, serotonin help us to sleep and feel good. You don't have enough serotonin, You don't sleep good, you don't feel good. Treatment, increase it. How? SSRIs. What I mean is SSRIs. Again, I'm going to simplify it. SSRIs. Let's say this is the synapses like this, and here's the other side. Let's say you are releasing serotonin here, okay? And it goes, and you feel good. Let's say you have just random numbers, 10 units, or 10 milliliters, 10 milligrams, whatever it is, okay? And you're completely okay. Sleep is okay. Your mood is okay, right? What if I have seven only? It can happen. Trauma or something natural, whatever it is. Something happened and you don't have enough. How to solve this issue? 7 units are secreted. I'm not feeling well. What should I do now? After you secrete those, you are going to reuptake it. You take it back. Release seven, you take the seven back. To solve this issue, block some of them from reuptaking. What if I block three? Look at this. Let's say this is 10. Okay? So now you're releasing seven. One, two, three, four, five, six, seven. How about this? I'm going to block those here. Block. No reuptake. So the next time when you release seven, three is still there. The total is 10. You feel good. That's it. Okay? So if one of us here and a lot of people, it's a very big percentage that are using this. So this is how it works. So when you hear SSRIs, selective serotonin reuptake inhibitor, it inhibits the reuptake. It prevents you from taking it back, so it accumulates and you feel good. Dopamine is another thing that's also related to motor problems. And dopamine, let me just simplify it again. Again, I don't want you to go any deeper than that. Acetylcholine control the muscle movement. Dopamine is the opposite. It increases your muscle movement. Acetylcholine control it. You lose it uncontrolled. Huntington disease. Dopamine increase your muscle work. If it is blocked, you have less muscle movement. And this is where you see, like in some, like Parkinson disease. Did we hear about this? Parkinson disease, like masked face. Why they are having masked face? You see somebody, like you talk to him, he's actually happy but cannot express it. He's sad but he cannot express masked face. It's not up to him. He doesn't have enough dopamine. So he cannot really move his muscles of the face that much because of the lack of dopamine. The opposite is using something like amphetamine. The amphetamine stimulate the dopamine. Aging, everything deteriorates, you name it. Think about anything, unfortunately, and it will happen. Memory, improve or decline? Decline. Intellectual function, decline. Controlling the reflexes, decline. The size of the brain, even the size of the brain, yes, decline. The number of cells, decline. Neurotransmitter, decline. Just put decline beside anything and you'll get it right, unfortunately, right? All functions just go down. So by doing this, if you have less cells, what happened to your spaces? Does it increase or decrease? Like the ventricles, the spaces. If the cells are less, what happened to the space? Become wider or narrower? What do you think? Spaces. It become wider. Look at this wall. Okay, the size of the classroom goes until this point. If you take part of this half, isn't this is increasing the space of the room, right? Yes. So the wall is like the cells. Less cells. Look at this. From this to this, shrink. Isn't this is getting bigger in between? Yes. The spaces become bigger. Brain size decrease. Weight decrease. Number of neuron, decrease. Memory, decrease. Spaces, increase. Blood flow to the brain, decrease. Synaptic organization, decrease. Neurotransmitter, decrease. Right? Not only that, but there are things that start to accumulate in the brain with age. Specifically, we're talking about like 70s and 80s and 90s. Like Ronald Reagan at the end of his life. Do you remember he was having Alzheimer's? Do we know that? He was having Alzheimer's at the end. Where does it come from? It is different things accumulate in the brain, specifically in the cortex. These things are neurofibrillary tangles. This is one thing that accumulates, and by accumulating together with something called the lipofuscin, but the tangles are more important. So neurofibrillary tangles and plaques, those two accumulate in the cortex, decreasing the function. I'm giving you the minimum again. What do I want you to remember with Alzheimer's? Alzheimer is an aging process, an issue that come with age. Decrease your memory. Why? Plaques and tangles accumulate in the cortex. That's it. Deterioration of the memory due to accumulation of those two. Memory consolidation, less. Secondary, less. Hearing, balance, vision, less, less, less. Reaction, less. Anything less. Dementia, translation, dementia. Dementia means the good brain activity. Dementia, you're losing your brain activity. And the most common is Alzheimer's disease. And that's it for this chapter.